Good morning, everyone. I am Bridget McCormick. I'm the Chief Justice of the Michigan Supreme Court and a member of, co-chair of the Human Health Subcommittee of CSG's Healthy States National Task Force. And it's my honor to kick off today's session. This is Making Mental Health a Priority, and it is a panel that our subcommittee is sponsoring, and I would like to acknowledge the members of the subcommittee seated in the front of the room. I am grateful they are here. We're going to be continuing our work tomorrow. Before we get started, a couple of housekeeping items. Please silence your phones, and if you could save questions until the end of the presentations, we will entertain them at that point. It is my pleasure to introduce our first speaker this morning, but before I do that, I want to just talk for a second about the importance of this topic. I don't think I need to tell all of you because you traveled here and you're in this room because you're curious, but the COVID-19 pandemic has certainly exacerbated and elevated the mental health concerns that were already pretty acute for all of us in our home states before the pandemic. It is the case that 4 out of 10 adults reported symptoms of anxiety or depressive disorder during the pandemic. And the kinds of solutions states were working on have just become more clear and more necessary. I know in Michigan we have been working on significant multi-stakeholder solutions to mental health problems in our communities, working across branches of government, with state and local government officials, and with community partners. And it is one of these issues where in a time of a lot of partisan rancor, there is a lot of bipartisan agreement. We find very few people who are not ready to roll up their sleeves and get to work on finding new and innovative solutions to the mental health crises in our communities. If you read the paper this morning, you'd probably noticed that Michigan became the most recent state with a terrible high school shooting. 3 students are dead. A 4th is might not make it. 6 others were wounded. It's just the latest example that we need bipartisan, creative, innovative solutions to give people the help they need with their mental health issues. So I am very excited about this panel this morning, but first I get to introduce Sarah Needler. Sarah is the Director of Research at the Council of State Governments Center of Innovation. In that role, she provides oversight and guidance to the Center of Innovation's policy research and technical assistance to states. She has extensive experience helping governments, nonprofits, and donors achieve better outcomes for the communities they serve by integrating research into actionable, evidence-based policy and programs. Sarah previously worked in state government in South Carolina. She was a Harvard Government Performance Lab Innovation Fellow with the South Carolina Department of Health and Human Services. And in that role, she supported evidence-based Medicaid policy. Specifically, she managed the agency's portfolio of substance abuse disorder programs and policies. She managed a project providing first-time mothers with nurse home visits to improve physical and mental health outcomes. And she managed other projects aimed to improve mental health outcomes for Medicaid beneficiaries across the state of South Carolina. Sarah earned an MA in economics from the University of British Columbia and an MPA in international development from the Harvard Kennedy School of Government. It is my pleasure to introduce Sarah, and she will take it from here. Sarah.
Hello, everyone. I'll take this off since I'm distanced from everyone here. It's really great to be here with you all today. Thank you so much, Chief Justice McCormick, for the introduction. Equally excited to talk about mental health policy. It's something that, as you heard from my introduction, has been something that I've been excited to work on over the years, and especially excited that we have been able to work on mental health policy as part of a project we just completed with CSG and with several state policymakers. So I wanted to begin our session today and tell you a little bit about that project and some of the things that we learned throughout that project. At CSG, and when we were talking to state policymakers earlier this year, we knew how much of a priority mental health policy was for our members and for folks across the country. And I think the pandemic really amplified a lot of those challenges. But in addition to amplifying some of those challenges, I think it also brought to light the importance of mental health policy, as well as really showing us what programs are effective and what works when trying to think about addressing mental health. And so we decided to start a project where we would convene a group of policymakers to come up with solutions for mental health. And we did this through a project that we started with support from the Commonwealth Fund. We started in January of this year, and knowing that mental health policy is such a huge topic to be tackling, we wanted to focus that in a little bit. So we decided to focus on 4 subtopic areas, which we selected with conversations from mental health subject matter experts as well as state policymakers, and decided to focus on these 4 areas of mental health policy. And those included social isolation, maternal mental health, health insurance parity, and social determinants of mental health. As you can see, these are topics that have been important both before and during the pandemic, but specifically some of these kind of have been highlighted as issues during the pandemic, so that we're excited to dig into them. We started this project by establishing a mental health advisory group. You can see all the names of the individuals who were part of that group on the screen. We had about 19 members of this policy advisory group. There were state legislators from 6 states, and then we had state executive branch health officials from an additional 8 states, as well as subject matter experts in each of the 4 subject topic areas. And I know we have a couple of folks here from the advisory group with us today, including Senator Becky Massey, who I haven't seen her yet today, but might be here. There she is. As well as Eddie Garcia, who is one of our subject matter experts, who's part of the panel today. So you'll hear more from him. And Senator Massey, as we go about this conversation, feel free to get up and add questions or help respond to questions as we go through this. So the Mental Health Advisory Group, we met several times over the course of about 9 months this year, and we had deep dive sessions into each one of the policy areas that we were focusing on. And along with those deep dive sessions, we also did some background research. Some of our policy analysts at CSG, including some of them in the room today, dug into what are all the legislation that has been passed around mental health policy in these areas. What's the academic literature look like around these areas? And then we used that as well as the conversations from the advisory group to develop a resource guide for state policymakers on mental health policy. And you can see here, this began as a smaller guide, but then kind of ballooned out into this very extensive resource guide, which was very exciting. There was just so much content to include. And you can see that what this consists of is first an executive summary, as well as policy briefs in the 4 policy topic areas, which go into examples of state legislation, go into the common challenges, common solutions, and then policy pathways forward for how we can solve some of these issues. It's also included in the resource guide are 4 data collection briefs. So this really focuses on what data should we be collecting around these policy issues, what research exists, how could we possibly evaluate some of these programs to learn what's effective and what maybe doesn't work so well. As well as 4 case studies. So this is a case study for each subtopic area in which we deep dived into a specific policy or program that a state has been implementing that has been found to be promising or has even had some research proving the effectiveness of that particular program or policy. And then 4 policy and research scans. So this is the extensive list of academic literature that exists on this specific topic, as well as scans of legislation across all 50 states. And that's the website link there that you can find the resource guide at. I know it's a bit of a long link, but we'll share it again at the end, and it should also be included in your app. The slides should be within there and the file shared, and then you can easily access the resource guide there. So before we move to the panel, I'm going to give a very brief overview of some of the findings that we have included in this resource guide. It's going to be quite high level, but then we'll dig into it a little bit deeper with some of our panel discussion. So the first subtopic area is social isolation. And as you can see here on the screen, kind of some of the key findings were that the pandemic really exacerbated an epidemic of social isolation and loneliness. And we found this to be particularly the case with older individuals and individuals in long-term care facilities. I think that's probably not surprising. We all have heard a lot about the challenges facing nursing homes during the pandemic, and this is something that we talked quite a lot about during our advisory group sessions and have included in the resource guide. And some of the ways that states have been addressing this particular policy area is by really trying to first define and identify social isolation and loneliness. This is a term that's been thrown around a lot, but has not necessarily had a common understanding of what that means in a policy space. So that's something that we've made sure to dig into a little bit deeper. And then some of the future policy avenues that I wanted to highlight here are listed here, and I don't want to go through them all because it's quite an extensive list, but I think want to point out a couple of them. And the first one being that social emotional learning curricula. And what that is essentially a curricula for schools, for students and for school staff to be able to assess student mental well-being. So an example of this is a Connecticut bill that has been used to create an assessment tool that will screen students that are at risk of suicide. So that's just essentially different tools and resources for thinking about social isolation in schools. Another example is the telehealth in schools. And we knew actually before the pandemic how effective school-based health centers have been in providing mental health services to students at the school place. And so using telehealth as an option, especially during pandemic and remote learning, has been really a promising avenue that we identified during the advisory group sessions. Another one that's on there, which might not be necessarily self-explanatory, is the geographically isolated professions. So one example that we talked about there was with farmers in Wisconsin. So Wisconsin actually has a farmers wellness program to provide mental health with remote options for farmers who might be working in very isolated rural areas, as well as some teacher education. And this kind of builds off of that social emotional learning curricula. But several different states have thought about how to incorporate training into teachers to help assess and identify students who might be at risk. So some of those examples include Illinois, which includes mental health in their license renewal, or Texas, who in their certification includes mental health. And then the last one I'll talk about for social isolation is around provider shortages. And this is really something that came across in all the 4 subtopic areas that we addressed, but really the need for mental health experts and mental health providers within all of these policy areas. And one example of that we talked about was in New Jersey, there is a budget proposal included for money for psychiatric residency programs. And this has been something that several states have been looking at, especially as the pandemic has kind of amplified the need for some of these providers. And I'm sure you're going to hear a little bit more from Eddie and the panelists during the panel discussion about social isolation. The second subtopic area is maternal mental health, which is a topic that was exciting to dig into and something that was, has always been problematic before the pandemic and during, but has made us think a little bit more about alternative access to maternal mental health services. So you can see here that a lot of the findings that we found were that mental health disorder diagnoses are rising, and that there's oftentimes kind of conflicting information about what's okay, what kind of medication can a woman use when she's pregnant, what is not allowed, and so that was a lot of what we talked about. You can see here again, one of the policy challenges is the provider shortages, as well as barriers to access. So what we talked about there, and that was really kind of the policy avenues that we mostly explored, was how to expand access and make access easier for individuals. And some of that included telehealth options, also included postpartum home visits. So this is actually something that, as Chief Justice McCormick mentioned, I worked on in South Carolina, which I know many states, including South Carolina, have these home visiting programs where after a woman gives birth, the nurses actually go to their homes, provide visits, checking in on mental health, checking in on the child, making sure these new mothers are doing okay. And that's something that a lot of states have explored adding Medicaid coverage for in their states. I know Maryland, South Carolina, Virginia, and there are others as well as expansion and extension of postpartum care beyond just a few weeks postpartum. So California and Texas have expanded Medicaid coverage, and states can actually do this under American Rescue Plan Act funding, is extending the amount of time that women are covered after giving birth. And then the next topic was mental health insurance parity. And this has been a topic that's been part of discussion around mental health policy for a really long time. And there's been a lot of measures that have been taken both by Congress and by state legislators to really require parity between provision of care for physical conditions and mental health conditions. But what we talked a lot about as part of the advisory group was even though these measures are in place, they're not always enforced or implemented. So we talked about a few different ways to enforce or ensure compliance with some of these efforts. And some of that we also talked about was establishing standards of care for mental health and substance use disorder. So an example of that was California, that's established 8 standards of care around ensuring treatment of substance use disorder. Another one on there that might not be self-explanatory from reading that list is the mental health redesign. That was another thing that we spoke about, in which there are some health advocates who actually are saying that there's a need to eliminate policies that separate mental health and addiction from overall healthcare delivery. So that was another interesting avenue that we explored as a group. And then the last one on there, which we also was part of all of our conversation, was really integrating the physical and mental health care. And we also have from the CSG Justice Center, the Director of Behavioral Health there, Aisha, who is on our panel as well, and will be able to talk to this a little bit more, as well as specifically in there, you'll see the part about law enforcement and behavioral health care. So we'll dig into that a little bit. And then the final subtopic area that we discussed were social determinants of mental health. And here, we had a long conversation at the beginning of what does that really mean. So I'm going to read you a list of what we defined as the 9 core determinants of social determinants of mental health. And that included racial discrimination and social exclusion, adverse early life experiences, poor education, unemployment, underemployment, or job insecurity, poverty, income inequality, and neighborhood deprivation, limited access to sufficient healthy food, poor housing quality and housing instability, adverse features of the built environment, and limited access to health care. So those are some of the things that we're talking about when we're talking about social determinants of health and mental health specifically. So you can see here, again, talked about a lot of different ways states can focus on policy around this area. But some of the more interesting ones that we listed there for future policy avenues include payment policy. And this is just getting states to think about how do we integrate payment for social determinants of health into payment for healthcare in general. One example of this is in Massachusetts, where they include social factors into their risk assessment scores when coming up with insurance rates. And then another one on here, which was an exciting thing to talk about, was the shared assets or resources. So we had some examples of networks of community-based organizations. I know we saw some examples in New Jersey and in Washington, where these organizations are working together to provide services not only for healthcare, but these other social determinants of health. And then also on there is the Children's Health Insurance Program, or CHIP. And there's actually federal guidance that's encouraging states to think about housing-related support, non-medical transportation, home-delivered meals, educational services, or case management as part of CHIP support. And that is, as I said, very high level of kind of some of the findings that came about in this resource guide. And here's the link again to that resource guide if you want to dig into it deeper. I'm also always happy to chat a little bit more. My colleague Sean Sloan is in the room, I know, and has worked extensively on writing and putting together the research for this resource guide, as well as Jessica Kirby, who is floating around the conference as well. So feel free to reach out to us. But for now, I'm going to give just a few minutes if anybody has any questions, comments. We'll have more time for questions after the panel discussion, but just wanted to give a few minutes here in case there are any questions about the specific resource guide or the project. Yeah, go ahead. There's a microphone there if you want to use that. That might be the easiest. Or you can always yell loudly.
Hi, I'm Senator Rodriguez from Santa Fe. Welcome to everyone. Thank you for being here. Let me just, I don't think I have any questions, but I was marveling at the amount of research. Can you hear me back there? At the amount of research. Maybe I can pull this down a little bit. Thank you. Marveling at the amount of research that you've done in those very key issues that we are not only discussing but introducing legislation here in New Mexico also. These are issues that have been in the forefront for many years, probably always truly, but they've been exacerbated now with this pandemic, and it's requiring much more of us to be resourceful, to be it's critical thinking and so on, to be able to truly make a meaningful change to improve the lives of people. And so it requires, as we know, more resources, more collaboration amongst each other, and just a lot of work, which we have to be committed to do to get it changed and done. So I just wanted to thank you. I would like to get a copy of the research guide that you talked about and follow up with that. So thank you very much for all that you do and for being here and holding your conference in Santa Fe. That's great. Thank you.
Thank you. And we're very happy to be here and happy to get that resource guide to you. I know one thing that was really important to us as the advisory group was making sure that we were having these discussions across branches of government, which is one thing that you mentioned, so making sure that we're working together, learning from each other. Go ahead.
I have one question. In your research, and you're looking at the ARPA funding. How are you? Did you come with any policy and looking how to leverage that money, and how would you do that?
Yeah, absolutely. So I think one way that we've talked about this, and we actually have quite a few resources on our website, which I can give to you. I think it's csg.org/recovery. But we have a few briefs actually specifically on how to leverage ARPA dollars for mental health. But one set pot of money specifically that it could be really helpful is the Coronavirus State and Local Fiscal Recovery Funds. So that's the funding that's going directly to states, and there's a high level of discretion on how that funding can be used. And so one of those is around health impacts of the pandemic. So a lot of states have been thinking about how to use that funding for mental health services, and really that can run across the gambit because there aren't too many restrictions on how that pot of funding can be used. So I know several states have thought about expanding or developing more infrastructure for behavioral health, a lot about training professionals, whether that's actually mental health professionals or it's general professionals so that they have more knowledge about what to be on the lookout for mental health when they're seeing their patients. But I can actually, maybe I can follow up with you and give you this brief that kind of outlines some of those things more specifically, and I'm happy to share that out. I'm not sure how I can make adjustments to the app, but maybe I can drop it in there as well, the link to that specific brief. Excellent. All right, well, I'm excited to hear from our panelists. So I'm going to go ahead and introduce our moderator for the panel, which is Director Adam Meier. He was appointed by Governor Greg Gianforte to be the director of the Department of Public Health and Human Services in January 2021. Previously, Adam was a partner and senior policy consultant with Connecting the Dots Policy Solutions, LLC. There, he assisted clients in health, human services, education, and workforce policy, focusing on breaking down operational silos to maximize program outcomes. In past government roles, Adam served as a secretary of Kentucky's Cabinet for Health and Family Services and served as Deputy Chief of Staff to Kentucky Governor Matt Bevin. Director Meier also serves as a member of the Healthy States National Task Force on the Human Health Subcommittee. With that, I will pass it over to Adam, who will introduce our panel.
All right, thank you guys. So I am wearing two hats. One is as the moderator, the other is as a panelist. So rather than awkwardly ask myself questions randomly throughout the presentation, what I think I'll do is I'll take about 10 minutes and just kind of walk through kind of what they asked me to talk about, and that's a state perspective on the challenges and some of the solutions and strategies that we're looking at least in the state of Montana as it relates to mental health. And then we'll move into the panel. I'll introduce the panel, and we'll move into more subject matter specific questions. So, as it relates to challenges in Montana, and I think you'll hear some that are going to be familiar to really anybody across the nation. As has been mentioned, we have been in a state of mental health crisis for some time. And really this pandemic really just exacerbated and put it in the spotlight. So our challenges though in Montana, some are unique. One with regard to mental health, we are similar to other states that have frontier rural. And so as was mentioned, I came from Kentucky and we had rural, and I considered Kentucky a very rural state. And then I moved to Montana, and then there's a whole different level of rural where you're seeing no people and no gas stations and nothing for miles and miles and miles. And so it really, when you think about the infrastructure needs that it takes with the lack of population density, it does create some new challenges. So that things like staffing shortages, workforce. We are all struggling with workforce, trying to fill our providers with direct care staff as they get into community, as our institutions, right? We're having trouble with psych techs, nurses, all of those things. So that's a huge challenge that we have. The acuity of the symptomology, the expansive distance between members and mental health services, especially in the eastern part of our state, that really frontier area. The capacity of our providers. So as workforce shrinks, or it becomes more unavailable, we're seeing our providers close down or limit their capacity, which leads to more need. And then a lack of technology infrastructure. If we want to expand things like telehealth, we have to have things like broadband to do that. Montana has among the highest suicide rates in the country. We have, I'd say, in some cases, extreme disparities with our Native American populations and their health outcomes, especially as it relates to mental health. And then, I think another thing, we see stigma associated with mental health, substance use disorder, all of those things across the country. But we have this kind of added kind of cultural thing that's new, and it's this kind of cowboy up mentality that we have in Montana, and that leads to things like self-medication rather than seeking treatment. So those are a few of the challenges that we were facing. And then, what I'll move into now is kind of some of the ways that we're trying to address mental health services in Montana. So there's a question about ARPA funding, so I'll talk about a few of the things that we've done with ARPA funding, and then move into a few other topics. But one of the things that when I came in, our children's mental health and our adult mental health were in two different divisions. And so one of the first things that I did was reorganize the department so that we could combine what was our developmental disabilities and children's mental health division with our mental health and addictive disorders divisions. That will help, I think, streamline some of the care, especially as it occurs to the co-occurring disorders that often accompany those with mental health diagnosis. We've also had a lot of collaboration to engage in a systematic review of our home and community-based services. Through these processes, we reviewed all aspects of the programs with a focus on improving quality of care, increasing operational flexibilities, implementing standardized assessment tool, implementing both process and health outcomes. This work has resulted in a differential payment for providers who serve frontier communities. So as I mentioned, right, it takes more resources to provide care in those frontier areas. So oftentimes we have, what may be an evidence-based solution or a provider rate, and we have to then change that or modify that just for the frontier approach. So that, for example, we have 115% frontier differential rate for targeted case management, home support services, school-based mental health services that are rendered to individuals in those areas that are in counties that are defined as less than 6 people per square mile. 46 out of 56 counties in Montana meet that definition. Currently, we're focusing on increasing capacity for in-state residential treatment, reducing the number of youth referred to out-of-state residential care. That's a huge issue we have. We are engaging in a comprehensive survey to determine current capacity and identify what is needed to serve youth with the most complex and challenging needs. Things like co-occurring ID and DD, along with a mental health diagnosis, significant aggression, sexually maladaptive or reactive behaviors, and overlapping complex medical needs. We are engaging with our providers, and we have a consultant, Guidehouse, who's come in to help us with that, to look at reimbursement models that might aid with trying to keep providers or allow providers to serve individuals in our state who have those needs. Prior to the public health emergency, we did implement a tiered assertive community treatment program in order to address the identified gaps in adult mental health treatment and the mental health continuum of care. This remains the core service. The tiered system also includes some gaps that we have filled. The intensive program for assertive community treatment, which is an intensive transitional packed service with a residential setting for members who need short-term supervision, stabilization, treatment, and behavior modification in order for a member to be able to reside outside a structured setting. And then the community maintenance program, which is intended to provide medication and community support for members who require long-term ongoing support at a higher level than traditional outpatient services to be maintained successfully in the community. And then we also developed a specific model for, again, for the frontier. So changing staffing ratio requirements, and those sorts of things that allow for those challenges in frontier communities to be addressed where they would otherwise go unmet. We also, Governor Gianforte, one of his signature initiatives was the HEART Initiative, and what that was is really a comprehensive look at our continuum of care as it relates to mental health, substance use, and looking how do we fill those, right? And so it really expanded efforts to use the state's evidence-based behavioral health continuum of care for individuals with substance use disorder, serious mental illness, and serious emotional disturbance, enabled prevention and earlier intervention of behavioral health issues, and monitor the quality of care delivered to a member with behavioral health needs in all settings through improved data collection and reporting. It was the largest expenditure that the governor put in his new budget. It did also allow us to better leverage federal funding to really expand the continuum of care. So what we did is we requested a 5-year Section 11 team demonstration to expand access to coverage for treatment for SMI, SED, and limited services for individuals 30 days prior to release from criminal justice system. So what that included was an evidence-based stimulant use disorder treatment model, including contingency management, tenancy supports, services for justice-involved population 30 days pre-release, and reimbursement for short-term residential and inpatient stays and IMDs. Montana will be implementing the HEART hopefully in the first half of 2022, pending waiver approval. As it relates to ARPA funds, a couple of different things, and many of these or all of these are probably available to states, so if you have questions on that, I'm happy to stay afterwards. I know I'm going a mile wide and an inch deep, but we have a lot of things going on. One is the home and community-based services, supplemental payments. So Montana is implementing a supplemental payment program to support maintaining a stable workforce and preserve significantly impacted home and community-based services for behavioral health provider networks. These payments are intended to support providers with increased cost of hazard and retention pay, higher staffing levels, PPE, and other supplies. We're using the Medicaid 10% FMAP flexibility that was provided through ARPA to do that. We're also undergoing a comprehensive provider rate study, primarily in Medicaid, but it does allow us to expand outside of that. So we're using ARPA funds, and these were the flexible funding that was mentioned. It's Section 602 to do basically a systematic review of our Medicaid provider rates. Behavioral health services have been prioritized as work begins in this month, actually, to complete the statutory analysis, service review, peer state rate comparison, with the goal of drafting reimbursement models that will really allow us to attract and retain providers, enhance our services, and enhance access to care. Through the child care funding, we provided temporary child care assistance for healthcare workers to help, really help attract and maintain our healthcare workforce. And then we also, again, with the flexible funding, created a relocation reimbursement for healthcare workers. So we have up to $4.3 million set aside to fund a program for certain healthcare workers, up to $12,500 in relocation expenses for each healthcare worker that relocates to Montana and works for at least 1 year. Telehealth. Telehealth has become really key, obviously, in the pandemic. And I will say that one positive I think that came out of the pandemic, there was many barriers to utilizing telehealth, HIPAA compliant platforms and all kinds of things like that really kept it from being the useful tool that it could be. And some of those were removed, and I think the pendulum has swung in such a way that it will never go back to where it was. But there still remains a number of challenges. But we did, to mitigate the spread of COVID-19, we did enable members to remain in their homes to reduce exposure and transmission to the extent possible, but also to preserve those services. So we extended telehealth services and really freed up the utilization of that where clinically appropriate and medically necessary. Some of the things that we did, rates for payments of services delivered via telemedicine, telehealth are the same that they would be delivered in a traditional medium. We're also engaging with industry experts to establish some long-term telemedicine policies. So as we come out of the pandemic, what does the future look like in terms of flexibilities, parity, all of those things, so that we can create a sustainable telehealth network. This is especially critical in telehealth or in mental health because unlike some physical health conditions, a lot of mental health conditions can be adequately treated and clinically appropriately done in a telehealth capacity. A few other things that we're doing to encourage individuals with mental illness to seek assistance. We are implementing 988. So we have a contract for planning, and we're in the process of expanding that so that we can have that stood up next year. In terms of prevention and early intervention, I'm going to run through just a number of programs that we have going on. And happy to stick around afterwards to talk about any of those. But one is First Episode Psychosis, which treats early psychosis, which affects about 3 out of 100 people at some point in their lives. With early intervention, some people have never have another psychotic episode. Drop-in centers, we use drop-in centers to provide low barrier access point for individuals experiencing mental health issues. Drop-in centers are peer-led and fill a unique and important role in our continuum. The existence of successful drop-in centers can have a major impact on the mental health system. For children, we're using the PACS Good Behavior Game and using evidence-based mental health promotion. Substance use disorder prevention intended outcomes. It reduces aggressive, disruptive behaviors in children while creating positive and effective learning environments. Prime for Life, a motivational intervention that is used in group settings to prevent alcohol, drug problems, or provide early intervention. It's been adapted for use with military personnel, college students, middle and high school students, and parents. We're using the community that care model, a prevention system that gives communities that tools to address their adolescent health behavior problems through a focus on empirically identified risk and protective factors. The Angel Initiative, which we just launched last week, basically creates an access point through local law enforcement agencies that allows individuals to request treatment for substance use disorder without consequence or questions, subject to some limitations, but this means they can go into a participating law enforcement office, turn in narcotics, ask help, and they will be connected to a treatment facility. We're using our state opioid response significantly for things like naloxone administration. And then integration of behavioral health into primary care is one way that we're looking to expand access to mental health services. And this is done through things like integration of medicated opioid use disorder screening, brief intervention and referral to treatment, and depression screening with FQHCs, CAHs, RHCs, tribal health, and especially behavioral health providers. So I know I went through a lot. Again, happy to address some of those in questions later or after the session, but I'm really excited to get into the panel. We have a fantastic panel of subject matter experts. So joining me on this stage are 3 accomplished subject matter experts who spend a lot of their time trying to improve health outcomes for people across the states. First, we have Karen Howard. She's the Director of Policy and Advocacy for Mental Health America. Karen has 13 years of experience in legislative and political affairs and advocacy. She educates and persuades federal and state policymakers to act on a wide range of issues that impact individuals with mental health conditions, including healthcare, education, criminal justice, and housing. She also facilitates relationships between state and local Mental Health America affiliates and their federal and state officials. Welcome, Karen. Also joining us is Eddie Garcia, Executive Director of the Foundation for Social Connection. In addition to that title, Edward is also the co-director of the Coalition to End Social Isolation, Loneliness, and the co-director of the Global Initiative on Loneliness and Connection. In each of these roles, he brings 20 years of experience working in government healthcare to entities dedicated to promoting evidence-based initiatives to reduce social isolation and loneliness, to promote global, national, and state and federal policy changes. Edward, it's a pleasure to have you here. And Dr. Aisha Delaney Brumsey, Director of the Behavioral Health Division of CSG's Justice Center. Dr. Brumsey oversees the division's portfolios which concern how parts of the criminal justice system intersect with mental health, substance use, and homeless systems, among others. Dr. Delaney Brumsey supervises a team of consultants and policy staff who help jurisdictions improve their delivery of services and outcomes for their clients. Aisha, thanks for being here. All right, so let's jump in. Aisha, first question is to you. From your experience in overseeing the Behavioral Health Division at the CSG Justice Center, what should state leaders know about the prevalence of mental health issues for justice-involved individuals compared with other populations? And second, how can law enforcement align with behavioral health needs?
Yeah, thank you so much. Can you all hear me okay in the back? No, not even a little bit. Okay. Is this any better? Yeah. Okay. So first of all, thank you for having me. Thank you for that question. And Adam, it was really exciting to hear about all the things that Montana is doing, especially ones that intersect with the criminal justice behavioral health population, which is of course what I'm here to speak about today. So, let me just scoot on closer. All right. Yes. All right. You know, it's early for me. I'm still on East Coast time. No, I think I've got it. Thank you, though. So first, the thing we should all know, and that many of you in the room are already familiar with, is that people with behavioral health conditions are vastly overrepresented in our nation's criminal justice systems. What we know is that people with substance use conditions are 13 times overrepresentation in our jails and prisons. People with serious mental illnesses, it's 3 to 5 times higher in our jails and prisons. And it's not just that kind of fact of overrepresentation that's important. What we also know is that outcomes tend to be worse for people with behavioral health conditions in criminal justice systems. They tend to stay longer. They tend to be exposed to traumatic events and to have other adverse outcomes like suicide and self-harm, and be at very high risk of death from overdose, particularly at the point of release and in the 2 or so weeks right after release. And while I'm talking more about what jails and the overrepresentation in jails and prisons, because that's some of where we have the best data, we also know from local data and from examples that disproportionate contact and those poor outcomes go across every point in the criminal justice system. So, for example, we also know that about 25% of all fatal police shootings are for people who have a mental health need. And so, just first, recognizing and understanding that is a serious issue is one of the first things that state leaders should do. But what I should say is that over the course of the time that I've been working on this, and certainly in the work we've been doing with the Justice Center, we're seeing more and more state leaders recognize that and take that challenge on. They've moved past the phase where we're really studying and kind of admiring the problem and have started to move into the space of implementing strategies that address those challenges. And I'll focus specifically on how communities are thinking about addressing the overrepresentation at that point of law enforcement contact. And this did not start just overnight. For all of you who are doing work at that intersection, you may be very familiar with the fact that over 30 years ago, there was a shooting in Memphis, Tennessee, of Joseph Dwayne Robinson. He was a 27-year-old black man who was in the midst of a psychotic episode, and he was self-harming, and he was fatally shot by Memphis police. And out of that came the first crisis intervention teams in the nation, in which specially trained law enforcement officers who have additional training in mental health began to respond to mental health calls. That was 30 years ago. Since then, we've been seeing more and more innovations where law enforcement and behavioral health are working hand in hand to not only say, who is it in our system that has a mental health condition and how are they connecting with law enforcement? How can we inflect that connection with law enforcement in such a way that it can be an opportunity to connect people to longer term supports? And we're seeing this in many communities. We call this police mental health collaborations. We work with a number of communities across the country who provide examples and peer-to-peer guidance for other law enforcement behavioral health agencies who want to stand up these interventions. And they have built a number of innovations. And I'll just give a few examples. So right now, we recently started working with Yavapai County in Arizona. So rural county, 8,000 square miles, which for those of you who are also sort of spatially challenged like myself, I looked this up, 8,000 square miles, about the size of Massachusetts. The sheriff partnered with their local behavioral health provider to say that I understand that when my law enforcement officers show up to a call for someone in a mental health need, they don't necessarily have the expertise to respond. I need someone else there with them. And they figured out a strategy to ensure that within 30 minutes of that call, a mobile crisis team of behavioral health professionals would show up to that call and would be able to intervene, help de-escalate any situations, and also connect people to ongoing care. And that is a remarkably fast response time, especially when many communities are looking at 24 and 48-hour response times for mobile crisis teams, yes, even over much smaller areas. And so that's where a lot of communities have been really building these police mental health collaborations, but we're also starting to see, particularly in the last 2 years, and somewhat in response to the conversations that have happened in the last 2 years around racial justice in the criminal justice system, there's real questions about whether or not law enforcement is always the best person to respond, full stop. And so many communities are also backing up before law enforcement to think about what are the interventions they need to put in place to ensure that if there is a call to 911 or if someone is in crisis, law enforcement doesn't necessarily have to be called. And we're seeing a fair amount of consensus that this is a good place for communities to start building interventions, both from law enforcement as well as from behavioral health and from community providers. And so what you're seeing is communities like Houston, Texas, where they placed a mental health professional in their 911 call center to triage the 911 calls that come in that are for a mental health need. And so that person can answer the phone and say, okay, what's going on? They can provide crisis counseling in that moment. They can connect the person to an appointment, and they can provide follow-up calls. Similarly, Austin, Texas, they were the first place in the country that when you call 911, the person that answers the phone says, are you calling for police, emergency medical services, or mental health services? And so they're using that point of the 911 call to really make sure that people are connected to the right response. And this is going to be important as communities start to implement 988 and integrate that into their emergency response system. And then finally, I would say that just like we know the crisis system is not just where you call, but it's who can go to you, we're seeing communities build out what we're calling community responder programs. And these are those programs where one of them, Denver, Colorado, the STAR program, when you call 911, if they can't support you on the phone, you do need someone to go to you, they're sending behavioral health professionals to those 911 calls. And those programs, the first one started in the 80s, but over the last 2 or 3 years, we've seen cities and counties across the country begin to adopt these. So I would say that the way that law enforcement is really aligning is that law enforcement and behavioral health have come together to say that we, one, recognize that we need to have real leadership attention on this issue. And that, two, we recognize that a law enforcement response and arrest is not necessarily a good outcome for someone who is in a behavioral health crisis. And so they have sat together, looked at their data, and implemented a number of interventions that make sure that people are connected at the earliest point of contact to supports in the community. So that's what I would say there.
Thanks, Aisha. And I do have a follow-up, but one other point I'd like to just make there. She excellently laid out all of the great reasons from a policy standpoint. How many legislators do we have in the room? Okay, so as legislators, right, you appropriate funds. And if you think about ROI and funding that you're appropriating, when they get to the correction setting, right, if you look at the top, your budgets, right, it's going to be healthcare, corrections, and education are your top spends. And if you look at corrections, it's almost all general fund. But if you look at healthcare and you're investing in mental health services, for example, in Medicaid, you're going to get a 75% match on that. So your ROI to invest on the front end as a legislator, as you think about appropriations, is significant from a prevention standpoint. Because if you can keep them out of correction setting, you're going to save money.
Mm-hmm. I would just, if I could, we did an interesting analysis of high utilizers or familiar faces or friendly faces, whatever term your community uses for people who have frequent contact with homelessness, emergency medical, and jail systems. And what we saw was that in some ways, Medicaid expenditures were higher, but savings were really great, especially if communities were able to put those dollars into supporting things like behavioral health care and case management, as opposed to, which prevented people from going into the emergency medical services and was more likely to reduce future justice system contacts. So.
Yeah. And so to that point, absolutely right. Where you invest in those resources, even within the healthcare setting, is critical, right? Keeping them in Montana, right? We had a cold wave hit, and we see a spike in hospitalizations. It's typically homeless populations that are going in for they want a warm place to stay, and so we see spikes in the utilization there. So a follow-up question: in your work in the Justice Center, what are the most powerful social determinants of mental health for justice-involved individuals, and how can states ensure communities have access to adequate behavioral health care?
Yeah, I thought this was a really interesting question. I really appreciated, Sarah, you laying out kind of what are social determinants of health, and the fact that where we live and play and where we grow up and where we grow old really affects our well-being and our health. And I would say that one of the things that I'm going to invert it a little bit, but I would say the very fact of contact with the criminal justice system is in and of itself a social determinant of health. And that means the fact of contact with incarceration, but also even with arrest, court processing, fines and fees, all of that can cause significant stress, all of which is in itself a social determinant. And I would say you have to think about the size of this social determinant. If we just look at incarceration, we know that communities had a pretty steep decline in incarceration during the COVID-19 pandemic, but as of March of this year, there was spring, so probably March, there was about 1.7 million people still incarcerated in jails and prisons. So that is a huge driver of health outcomes and a disproportionate driver of health outcomes for communities of color because of the disproportionate incarceration by race. And so you have to think, or what I think about when I think about how this is a social determinant is I think about when I've gone into jails and prisons and I see what the environment in so many look like. You're looking at often, for many places, older buildings that are either overheated, underheated, the quality of food is not high, people are isolated from their community connections. all of which causes daily stress. And then far too often at the higher end of what can be, can affect your health, those institutions are a place in which people are exposed, both staff and the people who are incarcerated there are exposed to witnessing and being subject to violence. And so that incarceration can drive so much trauma that it is in itself this key social determinant. For people with mental health and substance use conditions, some of the key factors of that are things like when you're incarcerated, you often don't have access to the care that you maybe used to have in the community. That's disrupted. And while providing health care is a constitutional mandate within correctional settings, far too often the quality of care in those settings is much lower than the quality of care that people would receive in the community. And I think about this one woman who I met when I was working on a project at Rikers in New York City. Rikers Island is the jail in New York City. She was arrested on relatively low charge, and it was pretty clear that she'd be out within 7 days. But within the first 2 or 3 days, she had started to decompensate because they weren't able to connect her with her medication in the jail. By day 4, she would have lost her bed in the shelter, which meant that she also was not going to be able to go back. That was a family shelter. She was not going to be able to get back custody of her children. That is a 7-day incarceration, which has now almost surely caused significant disruption to her life for the next several months and years. And so when I think about what it means that incarceration is a social determinant of health and mental health, it's those kinds of stories that I think about. So what states can do is some of what you've already heard spoken about today, but I think there's a few key principles. One is first and foremost is data. You need to know who in your system has a mental health and substance use condition. Second, you need to bring people together to say that this is a challenge that is important to both the behavioral health and criminal justice systems, and they're going to address it together. Third is ensuring that the quality of the care within the system is as high as possible and is commensurate with community-based care, and that you're expanding access to care. I was really excited to hear, Adam, what you were talking about with your 1115 waiver. We're seeing a lot of communities think about how to request those kinds of waivers and use Medicaid to increase access to care for people in systems. And then fourth is really ensure that the quality of your connection to care as people are leaving facilities is quite high, whether that's leveraging telehealth so that people know who they're going to meet with afterwards, jail in-reach specialists, ensuring that you have your continuum of care, your homeless provider in the jail to make sure that they're assessing for homeless needs and connecting people to housing afterwards. So those are a few things that I would say that states could do.
I would love to just mention that in the reconciliation bill that's expected to pass Congress, there is a provision that would turn on Medicaid 30 days prior to release. So that is certainly something that the waivers, that states should plan to include in their waiver so that young people and adults being released would have access to services right away.
Yeah, I appreciate that, yes.
All right, perfect segue. And we are going to move to Karen and stick on social determinants of health. So with that phrase, right, what does that mean to justice-involved populations? Can you discuss what factors contribute to youth mental and behavioral health needs across the country?
Sure. Thank you so much for the question. Thank you both Adam and Aisha for your very, very comprehensive overviews and wonderful programs and policies that you've discussed here today. Excuse my voice, I'm actually fighting a cold that's not COVID. So I appreciate you bearing with me. I'll try to keep my remarks as brief as possible so that I'm not torturing you. But I want to share a couple of statistics that I have from Mental Health America screening program. So Mental Health America is the oldest national community-based nonprofit organization dedicated to the voices of people with lived experience of a mental health condition or substance use disorder. It was started in 1909. And in 2014, we launched a screening program that would eventually, during the pandemic, see 10,000 users per day coming to take a screening. The most recent screening is for maternal depression, over which 75% of women who screen positively. And we also have psychosis, anxiety, depression, eating disorders, and many other screenings. Of the young people who are coming, because I think I was asked especially to talk about young people today, 66% of the screeners are ages 11 to 17 years old. We also know that by age 14, 50% of mental health conditions present themselves. So while young people are reaching out for help and experiencing difficulties, we're not quite yet ready to meet them where they are. And for Black youth, males in particular, they're experiencing the fastest rate of suicide across the United States. It's the number 2 killer of youth ages 10 to 24 years old. And with respect to the justice-involved population, 65% of children in justice-involved settings have a diagnosable mental health condition. So now I'll go to the question and give a little bit about what social determinants mean to people who are justice involved and what factors contribute to overall health and mental health. And we can't really talk about healthcare without talking about mental health care. So from infancy and from Sarah's report, we saw that from infancy, there are things that we can be doing to support mothers and infants and their mental health. Having a supportive caregiver that allows the needs of a young person to be expressed and to have those needs met is a really important part of their emotional and mental health. That safe space is and that safety is the number one important factor in whether or not a youth overcomes adversity and mental health conditions. In addition to some other kind of things that we can offer young people, including acknowledgement that environmental and climate exposures impact mental health, creating space for their ideas and creativity, acknowledging that young people are still developing their ideas, and meeting them with a trauma-informed response, whether that's in a home or in a community-based setting like a school, in addition to ensuring that their housing and food needs are being met. These all contribute to whether or not a young person may initially experience emotional disturbance and whether or not they are able to overcome that emotional disturbance. When there is a serious crisis or psychosis that presents itself in childhood, we do have young people as young as 5 years old now attempting, and 4 years old having suicidal ideation. Ensuring, like Aisha said, that there's high quality clinical response for them is greatly important. And in addition to adding mental health professionals to schools and in primary care and in other community-based settings, it's really important that we also think about how peers and other people who are the age of the young person might play a role in their recovery as well. Peer support is something that foster youth organizations are showing evidence of. When youth peers sit with other youth peers who are a little bit older but have sat in their shoes, there is remarkable results in validating the experience of the younger person and helping them to then connect to what would help them in recovery. And then I'll just I'll also say that with the 988 opportunity here, I think that it's really important that as young people learn the 988 number and start to dial it for help and start to text it for help, which will be available, we make sure that each state has a way to finance it in the same way that 911 is financed, so that there's enough funding for crisis centers, whether it's a stabilization center or a peer mobile crisis team that comes to meet them where they are, or other crisis model, that's kind of integrated into what will be a part of the response once 988 is tapped into. So hopefully that answered most of your question.
It did. So we've dived deep on justice involved, we've dived deep on youth. So I'm going to turn to Eddie and take it up a little bit higher level, and not look population specifically, at least right now, but you look typically at the more to do with the effects of isolation and loneliness across groups. So how would you define social isolation, and what are some of the adverse experiences that result from it?
Thanks, Adam, and thanks to the Council for State Governments for having me here and for exploring this really important topic. And I know it's important to all of you and to my colleagues, so thank you for that. The Foundation for Social Connection, which I represent, and the Coalition to End Social Isolation and Loneliness were founded for 4 reasons. 1, to raise national awareness around these issues. 2, to advocate state, federal, and local level policy changes across a comprehensive assessment. For the translation of scientific evidence into real-world solutions, and to support the development of new programs and policy solutions through our Innovation Accelerator. So we're happy to be here and happy to be partnering with all of you in that body of work. So Adam, to your question, I just want to make one very clear point here, that there is a real difference between social isolation and loneliness. And it's important that we distinguish that difference so that we can find the evidence-based solutions that most appropriately address those differences. So social isolation is really a state in which a person lacks engagement with others. It has minimal social contacts and does not lead to fulfilling or quality relationships. Social isolation can lead to loneliness, but that's really a feeling of being alone. So more directly, social isolation is objectively being alone and having few relationships and infrequent social contact, whereas loneliness is a subjective feeling of being alone and the discrepancy between one's desired level of connection and their reality. Again, the importance there is so that we can find the solutions that are targeted to the populations as needed. The impacts are very real, and they're not just on mental health. And so while I'm happy that we're exploring it in this context, there are many more beyond that. There are very serious impacts on our physical, cognitive, behavioral, and economic health. For instance, social isolation and loneliness are associated with a 30% increased risk of premature mortality. That's the same as smoking 15 cigarettes per day. It's also associated with increased risk of suicidality, depression, and substance abuse. It's increased risk of cognitive decline and dementia, and in the Medicare program alone costs $6.7 billion in increased spending. We need more data to assess the impacts across other federal programs and other populations on the economic side, and working toward that now. I'm sure it's going to be very, very large. Since the pandemic, unfortunately, we've seen between 20 to 30% increase of social isolation and loneliness across all populations. And that's correlated with increases in suicidality among younger populations and exacerbation of chronic physical and mental health conditions, as we're hearing. Emerging research is also suggesting that risk of social isolation and loneliness is associated with risk of COVID-19 infection itself. A survey of electronic health records, found that people with a mental health diagnosis are more likely to be infected, hospitalized, and to die from COVID-19 infection. Another study found that people experiencing interpersonal stressors such as loneliness have a greater chance of developing an upper respiratory illness after exposure to a cold virus. So in short, the impacts are vast, multidimensional, and multivariate. And we need to address policies that address all of those outcomes.
All right, thank you. That's a great overview of what social isolation is. So next, as a follow-up, as a state leader, how do I measure it? How do I identify social isolation, and what might I have access to collect data on social isolation as a state leader?
No, I appreciate it, Adam. And measurement, as we're hearing across the board here, and getting data on where we stand within our population is key. There are a number of tools, they're called scales or surveys, that are in existence that have been validated. Unfortunately, there's about 20 of them, and they measure different varying degrees of social connection and degree of subjectivity from the respondent, and assessing the function, structure, or quality of relationships. The most popular or most used scales are the UCLA 3-item scale, which assesses subjective feelings of loneliness and social isolation. It's widely used. It's a shorter version of a 20-question survey. And then there's also the Duke Social Support Index, which unfortunately is a 35-item measure of various dimensions of social support, including social networks, social interaction, subjective support, and instrumental support. Again, unfortunately, there isn't a standardized approach yet to measuring social isolation and loneliness, but there are scales there. There's a brief on the Administration for Community Living's website, on their Commit to Connect website, which is a federal program, a federal initiative that is establishing a network of community-based champions across the country with a goal of reaching 10 million Americans by the end of 2022 through programs deployed through the Commit to Connect website. So there you'll see a brief on a variety of scales that can be used. But Adam, to your second question on how to collect the data, 3 main points. Partnerships, I think you've heard that across the board here. Think about partnering with local public health departments, local coalitions, school health centers, area agencies on aging to deploy these surveys and to get new data in. Think about healthcare providers specifically. The UK has championed a concept called social prescribing for nearly a decade and have looked at social isolation and loneliness. They have a minister of loneliness, so does Japan, that is addressing sort of national strategies on social isolation and loneliness. The Gravity Project has been up and running for about 3 years, I believe. And the Gravity Project is developing new taxonomies, so new ICD-10 diagnostic codes, CPT procedural codes, and SNOMED codes, so that healthcare professionals can screen, diagnose, and refer patients to community-based programs to address a wide variety of social determinants of health, including social isolation and loneliness. And then finally, there's an interim tool, which is a geo-mapping tool developed by NORC at the University of Chicago in conjunction with the AERP Foundation, which provides sort of heat maps of social isolation risk across the country. And that can be found on connect2affect.org/map.
All right. So just a couple real quick follow-ups. First, are there populations that you see disproportionate rates of social isolation, and how should policy responses be tailored specifically to those groups?
Yeah, no, thank you for this. Absolutely. I'll just start by saying, before the pandemic, a large majority of Americans have exhibited feelings of loneliness, 61% and higher. And that was evident across all subpopulation groups, across generations, income levels, and gendered identities, with certain populations like Gen Z, LGBTQ, and older adults being most susceptible. But taking a closer look now at subpopulations, we see that Generation Z is by far the loneliness generation across the country, exhibiting 79% of respondents exhibiting loneliness or social isolation. That's compared to only 50%, which is still very high with boomers. And we also see that lower income populations are most vulnerable and significantly more likely to be lonely than their more affluent counterparts. So other priority populations we're seeing through recent data suggest that new mothers, caregivers, educators themselves, and healthcare professionals are exhibiting extreme levels of loneliness. But to your point, Adam, or your question, I'd like to take a moment to acknowledge what happened in Oxford Township, Michigan. So to Chief Justice, I send my condolences, we all do, and it hurts our entire nation. But it's truly showing that our data is showing that youth are suffering, and so are real world moments are showing us that. And I would suggest that we need to act on those priority populations immediately. I think we all agree with that. And we need to include those populations and those voices in the policy development process. Social isolation and loneliness and social connection are really tied to being seen, and so should our social policies. More broadly, I would suggest, and I think we've discussed that a bit up here already, looking at cross-sectoral partnerships and policy solutions. Also thinking about the standard public health model of socio-ecological model, looking at policy, organizations, communities, interpersonal and personal levels of impact. Our policy should be addressing that across sectors and thinking about those levels of impact. Truly no one-size-all-fits policy is going to be appropriate here, or nor one sector. In particular, for the high priority populations I've articulated, and I've said this earlier, we suggest partnerships with schools, healthcare professionals, after-school programs, intergenerational programs, senior living facilities, community housing programs, or through Meals on Wheels programs, engaging parks and green spaces, and public transportation, of course. So again, looking at social determinants of health. I would just like to quickly mention technology. While social media has come into the limelight for its deleterious effects, potential effects on mental health and social isolation and loneliness, one moment of caution or pause, that there are studies to suggest that for certain populations, even social media has a positive impact. I'm talking about in older populations, and when social media is used to connect people in face-to-face environments or to enrich the quality of relationships. I'm not taking a stance either way on it, but suggesting that we should look at the solutions for the populations that they're serving. Much more can be done, and much more that addressing this sort of socio-ecological model and this cross-sectoral approach will be coming out in a publication from our Scientific Advisory Committee Chair, Dr. Julian Holt-Lundstedt, in the American Journal of Public Health later this month.
All right. I do want to save time for questions, but did want to do a quick lightning round. Karen, long term, what are some key considerations that you hope all state policymakers take into account as they develop and continuously tweak their state's mental health support? If we could keep the answers to about 1 minute, 1.5 minutes, that'd be great.
Sure. I think for young people and ensuring that they're not going into the school to prison pipeline, I urge policymakers to take a look at the July report Mental Health America's team put out at mhanational.org/youth in crisis, where we make the case that mental health education in K through 12 schools should be required. New York State was the first to do it. Virginia and other states have followed. Allowing excused absences for young people's mental health sick days. Oregon was the first state to do so. That was led by students. Bills have been introduced in other states like Colorado and Maryland, especially investing in the professional and paraprofessional workforce. So that includes peer support specialists, which most states have included in their Medicaid plans. And then ensuring that during crisis, we are not responding with police, but police handle public safety. We are responding with mental health responses. A public health and healthcare response is extremely important to ensuring that young people who are justice involved are not going in the wrong direction, but getting the help that they need. So I'll leave it there, and hopefully with 988 being considered in most states, we'll have some additional action on these actions soon.
Thank you. Aisha, about half of individuals who experience substance use disorders also experience a co-occurring mental illness. In light of this fact, what policies best serve individuals experiencing substance use disorders, and how should states implement these policies to maximize their effectiveness?
Yeah, thank you for that. So I think one thing that's important to remember is that right now we're and have for a long time been in the midst of an epidemic of overdose deaths. This year is the first year that we topped 100,000 deaths, and states have been contending with this challenge for a really long time. So there are a few things that I would say that states can do. First is the divide between our mental health and substance use systems is not helping us at all, just as the divide between our behavioral health and our primary care or physical healthcare systems is not helping us. So setting up strategies to integrate mental health and substance use care, whether that means ensuring that your state actually has one single agency that is doing both, or whether there are liaison positions or other integration or other coordination bodies that are in place and are charged with making sure that mental health and substance use care in your state are integrated and coordinated. Second, as always, I'm going to say this a million times, you have to have the data. You need to know who has a substance use condition, how they're getting care, where they're getting care, and the outcomes of that care. Third, because drug use is, in many places, although increasing a little bit, there's some movement on this, it is illegal for most drug use, other than, of course, alcohol and tobacco, which has its own significant impacts. You need to think about the interaction with your substance use systems and the criminal justice system and ensure that you have systems in place to divert people as early as possible. And we're seeing a lot of states implement legislative strategies to ensure this, whether that means implementing strategies like allowing law enforcement to cite in lieu of arrest, or allowing law enforcement to transport people to crisis receiving centers or sobering centers in lieu of arresting people. Or implementing just pre-arrest diversion programs where people with a substance use condition or people who are found to be in possession of drugs, instead of arrest, are able to be connected to care. Fourth, you of course want to make sure that you're expanding access to behavioral health care, whether that's making sure that your first responders have and are trained in using naloxone to save people in the midst of an overdose, or whether that means that you're ensuring that you have providers who can support and provide medication-assisted treatment, and that there are no restrictions on the kinds of treatment that can be provided, especially within the criminal justice system. Too often we're seeing criminal justice systems determine that they're only going to allow certain types of medication-assisted treatment, which is contradicted by the medical system. And then I would say that making sure that you also have in place community-based services like peer respite centers and peer supports to connect people to longer-term community-based care is important. And then just broadly, one point that I haven't raised before is that as you're building these systems of care, we know that if we're not involving people with mental health and substance use conditions in talking about what the problems are, designing those solutions, and operating and leading those solutions, you're really leaving a lot of creativity on the table, because the people who have the most experience of the challenge are going to be the people who are going to bring your most creative and effective solutions. So I think those are some of the things that I would ask states to think about.
I'm going to end there, if that's okay with you, Eddie, so that we have some time for questions. With that, if you have a question, if you'd walk to a microphone so that we can hear and everybody can hear.
Hi, I'm Jennifer Boysko. I serve in the Virginia Senate, and I think what you're talking about is like moving a giant monolith. We have been trying to make a lot of those changes, and I'm interested in hearing how you can help us use language that is in a bipartisan spirit, because that's where we come to loggerheads a lot of the time, where people are afraid of, especially around the justice system, are we going to support law enforcement, or are we going to get behind people who are the criminals? And how do we manage that in a way that everybody sees the benefit? That's my question and concern.
One thing that
Sorry.
are you calling on people?
I was going to really quickly, Carol, do you mind? I'll pass to you. One thing that I would say is that's a huge challenge. But first and foremost, what I have learned doing this work is that you will find champions everywhere. So it means one thing to have Aisha Delaney Rumsey, who lives in Brooklyn, tell you this. It is a very different thing to have your local sheriff sitting next to your behavioral health provider and say, both of us recognize that this is a challenge that we can address and that we think is important. And I'm hearing law enforcement officers say to me, and chiefs, we don't think that we're the best people to respond to these calls. We really want someone else to answer that 3 a.m. call. And so I think having those voices and both articulate that together is one strategy that I found to be really important. Sorry.
And to build on that, one of the things, the Denver Star program was mentioned earlier. They actually sat down at the table with behavioral health professionals, the state officials, law enforcement, and peers or people with lived experience all sat down together at a round table and decided what would work best. And I think I agree. Law enforcement always says, we don't want to be handling this. We'd rather do public safety.
And I would just echo, I think, finding champions, and I know there's a couple of Kentucky senators that are here, and a great example is in Kentucky, the number of harm reduction locations. That was something that typically is going to be it can get very partisan, and we were able to pass legislation that allowed for local counties to expand harm reduction in their counties. And I think Kentucky now has the most harm reduction locations in the country. And so that's an example where if you can find people that are willing to step out and let it grow, be community driven. And then the other thing I would recommend is having people go and meet with people who are coming through recovery, right? Go to we took legislators to one of our evidence-based programs in a correction setting where they were able to interact with people who had come through recovery, who are incarcerated, going through a recovery program. And it gives context to people to understand the challenges that got them there. So I think that's another strategy I would say.
There was a conference a couple weeks ago where Wisconsin legislator John Spiro spoke, and he highlighted Wisconsin's task force where they did actually create kind of a set of objectives for the community, and they came up with a comprehensive bill, which everything won't pass at once, but you'll have kind of a blueprint to go from there. And so it may be worth reaching out to him or somehow figuring out how Wisconsin was able to do it.
Yes.
I don't know if you want me to just speak loud enough, but I'm Susie Christensen. I'm chief of our Iowa Supreme Court. There's so many people in the room that are legislative and executive. I feel like a fish out of water, and I'm sure my colleagues agree. We don't ever get involved in policymaking. We can't. But I was on a similar committee at an Iowa level, and I was the only judicial person sitting around the table. And I just want everyone to know that we only deal with this issue when it's on fire. On fire. It has to be filed. And for a child or an adult to get to the point where they have become a part of the legal system, obviously a lot of things have happened. And so I'm listening very intently at more of a grassroots effort to help. Unfortunately, we may not feel the benefits of that for a while because we deal with the fires. So I just wanted you to know I'm quietly sitting here. I don't have much to say. I can't have anything to do with policy making other than we are affected by the work that you do. And we can't be too vocal about it, but we certainly we do have a dog in the fight. We just don't get to get into the ring.
And I do think it's important to involve the judicial branch in policy, right? And we've seen some really good success in drug courts across the country. And that's a way to have an intervention prior to people be going into the system and not coming back out, or coming back out worse than they came in. So I think it is critical. You raise a great point. And I do think that you guys can play an incredibly important role in helping be part of the policy solution and the outcome solution.
Thank you. Rebecca Alexander from the state of Tennessee, a state legislator. Several things I'm concerned about. First of all, let me respond to what you just talked about. We're having tremendous success with our drug courts in East Tennessee.
We have those too. I should have mentioned that. I actually started one myself, but
great.
We do.
Thank you for that. It's wonderful. And we're working on getting a long-term care treatment facility for drug users because the statistics are out there. The longer they stay in treatment, the less chance they'll have go back to their bad, behaviors or their addictions. But several things crossed my mind as we talked today, and I hear you all speak. The thing that is concerning, and I think the root of the problem here, is our family unit dissolving, because when the family unit is dissolved, then you've got great grandparents trying to raise their children, and then all the different things that happen with that. Homes that have addicted parents on drugs, homes where there's not a father involved. I'm just wondering how I can remember when I was pregnant with my first child, going to a maternity conference, and the physician said, the greatest gift you'll give your children is the security in knowing their mom and dad love each other. How do we get back to those basics? I mean, these programs we're putting into place are fixes for a root problem. How do we get back to the basics of getting our family unit back together, keeping families strong and together? Any advice?
So I'm reading a book right now called Endgame. It's an excellent book, and it talks a lot about how faith and community-based organizations can play a larger role in relationship counseling.
Yes.
And how, so as an example, in Jacksonville, they implemented this program. Jacksonville had the highest divorce rate in the state of Florida, and in 3 years, they were able to decrease the divorce rate by 24%.
It's huge.
Yeah, so I think there's it's all about partnerships, right? We go out partnerships, and everybody can play a role in this, and that includes faith and community-based organizations coming alongside of state agencies and being able to work together on achievable and obtainable and well-defined solutions. I think that's where it starts, and then working across executive, legislative, and judicial branches. So I think that's at least one starting point. I'm happy to talk about some of the things that we're doing in Montana to help address that as well. And with that, we'd love to bring Justice McCormick back up to close this out.
I want to thank our panelists. Let's give them a big round of applause. And all of you for being here and staying and being so engaged and asking great questions. I want to echo a couple of the things I heard said from my own experience in Michigan. I've spent the last couple of years chairing the Governor's Task Force on Jail and Pretrial Incarceration. Michigan, like many states, has seen its county jail populations triple over the last 30 years, even though crime is at a 50-year low. Also, like many states, we didn't have any statewide data to be able to understand exactly why that had happened. With the help of the Pew Charitable Trust, we collected that data, and you won't be surprised to hear the role that mental health and substance abuse has played in that expanded jail population. Our task force was bipartisan, state, county led, and had significant law enforcement participation, and we heard from every facet of law enforcement. They don't want to be the first responders to mental health crises. They're not trained for it, it's not fair to them, and they've been incredibly powerful at our policy table at making Michigan what I think will be a national leader in jail and pretrial reform. So pull law enforcement in, they're helpful. I also wanted to thank you for the specific engagement on how we can work together to solve this problem. I agree with my friend, Chief Justice Christensen, that judges are an important part of this solution. We are seeing the very downstream effects of not getting this right upstream, and we'd like you to put us out of business. So let's move our solutions upstream. Thank you all.
Thank you.